Hi, my name is April, and along with Caitlin, Trisha, and Gracie, we'll be explaining the cartilage in bone. So, cartilage serves as the embryonic blueprint for bones. Cartilage is laid down first and will form into bone through a process called perichondral ossification. Cartilage also forms joints because it is able to slide across each other easily while bearing weight and acts as a cushion for bones due to its limited compressibility. Bone provides skeletal support for land animals, protects vital organs such as the brain and lungs, and is the site of hematopoiesis. There are two types of bone, compact and spongy bone. Compact bone forms the outer shell of bone, providing strength and protection, while spongy bone is the site of blood formation. Bone tissue is continuously remodeled through various actions of different cells, such as being reabsorbed by osteoclasts to remove old tissue, and bone tissue being formed by osteoblasts. Our first disease is osteoporosis, which is characterized by an imbalance between osteoblast and osteoclast productivity, where bone tissue is being absorbed at a greater rate than bone tissue can be formed. This decreases bone density, creating holes in the bone and making it more prone to fracturing. And development of osteoporosis can be attributed to many factors, such as sex, with women being more likely to develop osteoporosis than men, increasing age as osteoblast function decreases over time, being of a certain race, having a family history of having osteoporosis, having a small body frame, since these individuals have a lower peak bone mass, and low calcium intake. Low levels of sex hormone and an overactive thyroid, parathyroid, and adrenal gland can also increase your risk of osteoporosis. Most notably, having hyperparathyroidism can cause osteoporosis, as oversecretion of parathyroid hormone stimulates osteoclasts to break down bone at a greater rate than bone can form. Notably, most postmenopausal women have the highest risk of developing osteoporosis due to their age, sex, and changing estrogen levels. For symptoms of osteoporosis, it is known as the silent disease because no symptoms are experienced until a bone is fractured. Afterwards, individuals can experience weight loss, a change in gait, a loss of muscle density, and on a histological level, having thin, disconnected trabeculae, an increase in osteoclast, having uneven osteoclast, and a degradation of adipose tissue within the bone marrow. And the discontinuity of trabeculae is also directly related to the severity of the illness. So in this diagram, you can see two images, and on the left, we have healthy bone tissue, and on the right, we have osteoporosis tissue. And as you can see on the right, there's a lot more gaps and just really uneven bone, and that is all the trabeculae that has been degraded due to osteoporosis and having osteoclasts break down the bone.
Diagnosis and treatment of osteoporosis. So diagnosis of osteoporosis normally comes from routine procedures from elderly citizens 65 years or older, as they are typically at a higher risk for the disease. The very common screening procedure used for this is a BMD machine. So over here on the right, you can see the bone densirometry scan, and it is essentially just like a x-ray that the patient can lie down on, and you can see the caregiver is able to fully assess their bone density and see how at risk they are for fractures. The treatment plans that will follow are based on the perceived likelihood of future fractures. If it is seen that a patient is at a very low risk for these bone density fractures, then they will likely just be prescribed a few lifestyle changes or calcium supplements, exercise, increased calcium intake with diet, things like that. However, for patients that are considered higher risk, there are some medications that may be prescribed either orally or intravenously. Some of these medications include biophosphates like aldrinodate or risdiplam. And these biophosphates work by slowing down the osteoclasts in the bone and thereby slowing down bone loss and allowing the osteoblasts to work more effectively to kind of rebuild that bone density and prevent fractures. Another medication that is commonly prescribed is denosumab. And this works by blocking the osteoclast differentiating factor, which kind of inhibits osteoclast formation, and again prevents a rapid breaking down of the bone and allows the osteoblasts to rebuild some of that bone density that has been lost. For older women, particularly those who have just begun menopause, they may also be prescribed different hormone treatments. And these treatments work by increasing the bone density and bone production, but it doesn't stop the osteoclasts. It just kind of gives the osteoblasts a boost, which still has the same effect of minimizing fractures, although it may be less likely to minimize non-spinal fractures. These treatments will all vary significantly in how long they must be taken, how often they must be taken, whether they're oral or injections, all these different kind of things. But they are very effective medications in treating those with osteoporosis. Oops.
Rheumatoid arthritis is an autoimmune disease that occurs when the immune system attacks healthy tissues and cells and mistakenly sends antibodies to joint tissue. These antibodies then attack the surrounding joints and the joints become inflamed. The cause of rheumatoid arthritis is not yet known, but there are several genetic factors that are expected, such as environment, age, and genetics. Symptoms of rheumatoid arthritis include joint pain, swelling, stiffness after inactivity, fatigue, poor appetite, and weight loss. The joint pain associated with rheumatoid arthritis is caused when the joint tissue lining the joints becomes inflamed because it's being attacked by those antibodies. Fluid builds up in the synovial membrane, and the joints eventually degrade and break down. Cartilage serves as a cushion for these joints, and so because it's broken up, this causes friction during movement, resulting in that pain at the joint site. Stiffness after inactivity and in the early mornings is due to the absence of cartilage at the joint. Individuals with rheumatoid arthritis may experience fatigue due to the antibodies that attack cartilage at the joint site. This affects not only the joints because it's an autoimmune disease, but also the central nervous system, hence the symptom of fatigue, which makes the patient feel more tired. Due to fatigue, the patient may also lack energy to perform simple tasks such as preparing meals, which then can result in poor appetite, which then can result in the weight loss. Rheumatoid arthritis makes it difficult for the patient to engage in healthy exercise, hence also the weight loss, and even participate in daily activities.
Hi, so I'm going to be talking about the diagnosis and the treatment of rheumatoid arthritis. So the diagnosis of rheumatoid arthritis can be kind of tricky, and this is because the early symptoms of the disease are similar to those of other diseases such as lupus, scleroderma, and osteoarthritis, which leads to the diagnosis requiring more attention and testing so that it can be diagnosed accurately. In addition to this, it is best for the disease to be diagnosed about 6 months after the onset of symptoms so that the patient can start to receive treatment to help manage the symptoms and the pain. So for rheumatoid arthritis to be diagnosed, patients first have to undergo x-rays and blood testing, and the blood tests are to look at erythrocyte sedimentation because people with the disease tend to have a higher rate of that. In addition to this, they will undergo a physical examination where the doctor will look at their joints and their muscles because those are affected by the disease. And one of the most important factors in the diagnosis is that the patient is seen by a rheumatologist. And since they specialize in rheumatoid arthritis, they are just better suited to recognize the symptoms and correctly diagnose it, as it's easily confused for other things, as I said earlier. So for treatment, there's two main types of medication, and those are disease-modifying anti-rheumatic drugs, also known as DMARDs, and biological response modifiers, and those are usually used as a second option taken along with DMARDs. So disease-modifying anti-rheumatic drugs aid in slowing down the disease's progression and preventing or lessening some of the symptoms, such as joint pain or swelling. These work by subduing the immune response that causes the body to attack its own joint cells by basically holding back the B and T immune cells. And it also subdues the inflammatory response, which causes the swelling and pain that is seen in rheumatoid arthritis. And so common DMARDs are methotrexate and leuthimide. And then for biological response modifiers, those work by blocking the chemical signals in the body's immune cells that lead to the joint inflammation and pain that is caused by rheumatoid arthritis. And one of the most commonly used biological response modifier is abatacept, and it's usually taken in conjunction with methotrexate. And then lastly, anti-inflammatory drugs are also used to usually lessen the pain that is caused by the disease, just in addition. And so for the pictures, excuse me. So here is a picture of normal synovial lining, which is only a few cell layers thick. And this is synovial lining that's affected by rheumatoid arthritis. So you can see how it causes damage to the synovial lining of joints by just, which in turn makes it thicker because the cells are reproducing more. And then this purple picture on the left is a picture of inflamed synovial tissue, and the one on the right is a pannus, which is a type of invasive synovial tissue that causes joint erosion. And then this is a picture of Weichelbaum's lacunae, and it is characteristic of rheumatoid arthritis, and it causes enlarged chondrocyte lacunae in the articular cartilage. And this is caused by the death of chondrocytes. And basically the bigger spaces or the bigger lacunae are because cells are dying because the immune system is attacking and killing them. So when the cells die, they leave a bigger space. So we have some questions now. So the first question is, which factor in this photo is the cause of osteoporosis? A, lower than normal osteoblast activity. B, an abundance of osteocyte activity. C, an abundance of osteoblast activity. D, A and B, or E, A, B, and C. So the answer is A and B. It's a combination of both the lower than normal osteoblast activity and the higher than normal osteocyte activity. So then we have which photo is affected by osteoporosis. So we have photo 1 and photo 2. And the answer is photo 2, and you can tell that it's affected by osteoporosis because the bone is a lot less dense and it's a lot more brittle, and you can just tell that the overall structure is a lot more sparse and there's less matter in it. For question 3, which images are correctly identified? A, normal synovial lining. B, synovial lining affected by rheumatoid arthritis. C, bone affected by rheumatoid arthritis, or A and B, or A, B, and C. The answer is A and B, and as we showed earlier, this is the synovial lining that's only a few cells thick, and that's like the healthy kind, and then this is the thicker kind that is affected by rheumatoid arthritis. And then this is just bone, and rheumatoid arthritis doesn't affect the bone, so that's why that one's wrong. And then in question 4, in this photograph of a joint affected by rheumatoid arthritis, what is the indicator of the disease? And the answer is the enlarged lacunae, which is Weichelbaum's lacunae, that is caused by the death of chondrocytes. And then here are our works cited. We'd like to thank all of our sources that helped us get all the information for this presentation. Thank you.